So I would like to thank the conference organizers for inviting me to speak on progress and lack of progress on DTG transition in Africa. I have no conflicts of interest. And this is going to be my presentation outline. So speaking about the historic perspective of ART transition, despite the progress in ART coverage in children, achieving the target of 95% viral load suppression has remained elusive in children. And as you can see on the left, we've progressively seen more children being started on treatment, but the viral suppression has been low. In 2019, it was still at 68%. And a major need to achieve the 95% viral load targets remains optimal pediatric ARV regimens and formulations. And for those of you who have been in the business of treating children for a while, I'm sure some of these medicines are familiar to you, where we started with syrups, where a child of 5 kg would be carrying home about 5 bottles for 1 month. And then later on, we started receiving fixed dose combinations, and then moved on, got Calitro, which was more effective. And these medicines require transitioning children to the different medicines that were coming, as WHO was recommending new guidelines. And this slide shows that historically pediatric transitions have been slow. On your left specifically, if you look at abacavir, the WHO recommended abacavir way back as far as 2010, but we see that the transition to abacavir-based regimens have almost taken over 5 years. And on your right, same story with lopinavir, ritonavir, and efavirenz, whose uptake has been quite low over time. So speaking about DTG, this slide talks about the story of DTG, and I want to thank Martina from the WHO for sharing it with me. And so in July 2018, research networks rapidly shared data to inform simplified guidelines for use of DTG in children, and WHO revised the guidelines and included DTG. And in 2019, we see that 20 of the 21 priority countries adopted DTG, and in June 2020, investors accelerated submissions that led to approval of DTG use in younger children. And of course, later on, thanks to existing licensing agreements and targeted incentive programs, the first generic versions of DTG 10 milligrams, the squad tablets, were approved. And we also saw an unprecedented price deal that reduced the price by about 75%. And in June last year, again, thanks to regulatory reliance mechanisms, catalytic procurement and coordinated efforts among implementers and procurement agencies, so DTG 10 milligrams has so far arrived in 4 countries, including my own Uganda, and will be in 19 countries by the end of the year. And this is just an oversight of the WHO guidelines, and we can see that in 2019, WHO recommended DTG for children, for all children, as the first-line regimen. And on the right, WHO also provided guidance on how to transition children who are stable from their current regimens to the recommended regimens as per the revised guidelines, including DTG. For example, we saw a recommendation to transition children between 20 to 30 milligrams who are on NNRTI-based regimens to abacavir 3TC and DTG. So this guidance is what countries use to adopt to their own national guidelines and to use to guide their transitions within the country. And this is an excellent pictorial that Chai has developed, and it talks about the entire process of introducing a new product into the country, right from the point of adoption and decision making to the monitoring and uptake of the new product that comes into a country. It has several steps, and I encourage you to look in detail in this tool. But today I'll concentrate a lot more talking about the steps that happen within the country. So going straight to DTG rollout experience, I'm going to speak about the experience of 3 countries. So the first is Kenya. So Kenya started the DTG, the optimization process, and especially focusing on DTG in 2019. And we see that they had a phase process where they had phase 1 and phase 2 of transition. And in each of these phases, they had the targeted number of children that they were transitioning. For example, in phase 2, they were transitioning about 32,000 children who were on efavirenz and 16,000 who were on lopinavir to DTG and LPVR 2-in-1 pellets. And on the right, we see that within a period of 5 months, the proportion of children who are on DTG-based regimens increased from 16% to 56%, which is an excellent performance from within the country. In the neighborhood of Kenya is Uganda, and Uganda had a similar plan of transitioning. So they developed the guidelines, developed a rollout plan, prepared training materials, and implemented monitoring through routine data calls with partners. And Uganda was doing the same, transitioning children under 20 to LPVR-based regimens and those who are 20 and above to DTG. And we can see that in Uganda, by March this year, 85% of the of older adolescents were on DTG-based regimens, and 14% of the young adolescents, 75% of the young adolescents were on DTG-based regimens. And they're beginning to see payoff of the optimization process. On the right, you see that the trends in viral loads are increasing over time, both for children and for adolescents, which the country attributes to the optimization process. In Tanzania, this is data from the BPI clinics in Mwanza and Mbeya, and I want to thank Bacha for sharing this data with me. So they transitioned about 80% of the children who were eligible for DTG, that is those above 20 kilograms. And in the transition process, none of the children experienced severe drug toxicity. And there was viral load suppression increased from about 86% before DTG to 92% after DTG. So this was an excellent example of how DTG is well tolerated and effective in children and adolescents living with HIV, encouraging results. So now talking about the pediatric DTG, its uptake and key actions to promote transition. One of the major actions is inclusion in the national guidelines. And this map shows the countries that have included DTG in their guidelines and as well adopted the 10 milligram DTG and have made plans to procure. So we see that there are about 6 countries in light green who have gotten catalytic procurements by CHAI, as I'll talk about shortly, and those in blue are the ones that have made plans to procure DTG 10 milligrams. The countries where data is not may need to be supported, or teams may need to reach out to them to understand what is happening within there. But it's important to be able to support all countries to adopt new guidelines. And still, key actions to promote transition. There's need for a transition strategy and a rollout plan for new pediatric ARVs. And this should include discussions on how to handle available stock of medicines that you're going to transition patients from, as well as developing capacity building materials, monitoring plans, and reporting. And more importantly, the rollout plan. So on the right, I've put up the rollout plan for Uganda and how they are planning to roll out the pediatric DTG, which is already in country. So they have 3 phases, with phase 1 starting in August and phase 2 starting in October and phase 3 in January next year. And in each of these phases, they have specific targets of children that they're planning. So this is critical. They're planning to transition to DTG. This is very important in informing the procurement plans for the medicines, and countries should be doing things like this. So again, the other critical and important action is to ensure that your supply chain is functional and there's stock availability within the country. So CHAI and United, through the Optimal Grant, have procured catalytic pediatric DTG for 6 countries. And that is Nigeria, Benin, Uganda, Kenya, Malawi, and I don't remember the last one. But these medicines are going to help to ensure that there's accelerated access within the country, and they will generate new evidence, especially looking at acceptability of these medicines and monitoring for outcomes. And medicines have already arrived in all the countries, in 4 of the countries, including Uganda, and they procured about 100 packs across the 6 countries. This is a one-off procurement, and it should be able to take a limited cohort of patients for about 12 months. But there's need to be able to engage other support and organs and donors and countries to be able to make plans to procure more medicines for the other children. The other considerations that are important is patient monitoring tools, pharmacovigilance, and patient education, which we should not underestimate. Without the buy-in from the patients and without the education, you will not succeed in implementing the transitions. And importantly, I also want to bring our attention to the fact that even as we wait for the 50 milligram DTG, for the 10 milligram DTG, we should maximize the use of what we have at hand, and that's the 50 milligram DTG. I have shown here a graph from still Uganda. Initially, I showed you where we're looking at the proportion of patients on different regimens by age group. But there's a very important need for us to transition to begin to monitor by weight bands. As you can see on the right, we see that for children 20 to 29 who are eligible to be transitioned to DTG, we still have over 30% of them who are still receiving suboptimal regimens, and they need to be transitioned to DTG. So this highlights the need for continuous quality improvement. For example, clinics will need to line list these patients and target them for transition. And as well, we see here that even before the rollout of the guidelines, we're already seeing 77% of children under 20 on DTG, and which is likely a data quality issue. So I put this here to highlight the need for countries to have good data management systems and ensure data quality, so that we can have correct data that can inform procurements and forecasting. And I also want to say that DTG alone is not a magic bullet. It is just an additional tool to the toolkit in achieving viral suppression in children. There are key things that we must pay attention to as we transition patients to pediatric DTG, and that is adherence, retention, disclosure, and psychosocial support. We need to go beyond numbers and focus on the child and the family. And I want to end by telling you my experience as a doctor in a rural clinic in Uganda. In 2007, we were providing pediatric ARVs with syrups. And then we got Triamine Baby, which is a D43TC and Nevirapine, a dispersible tablet, and we're all very excited. We put children on these medicines. And we had this one child who consistently came to the clinic, brought by the uncle. They never missed an appointment. But the child was failing on he was getting worse on treatment, and we're considering switching the child to second line. And we asked one of our nurses to do a home visit. When she reached home, she was shocked. She found that the child was living with a grandmother who was partially blind, and all the medicines that we had been given were in one corner in one room in the house. And we discovered that the uncle who was bringing this child never lived with the child. He would come from about 5 kilometers away, pick the child, bring to the clinic, and take the medicines and leave them at home without telling the grandmother anything. So we realized that we were actually counseling the wrong caregiver. We should have been counseling the grandmother rather than the uncle. So without paying attention to those details, you fail to manage children. We need to pay attention to the family and to psychosocial issues if we are to succeed in transitioning children to DTG 10 milligrams. Here are some tools that you can look at, excellent tools for supporting transition at country level. And I also want to acknowledge some of the people that we worked with to be able to prepare these slides. Thank you so much for your support, and thank you for your attention.